All right. Thanks for everybody for joining us. I'm Dr. King. I'll be the moderator of today's ACAFAS Journal Club. We're joined by Dr. Celine Guerrero and Dr. Wynes, who is in an airplane right now, so he may not be able to speak for us. And then we also have, and there's a poll that's just popped up for everybody if you can answer who's with you, and then you can close it. Um, but we also have Dr. Baker here with us to represent PICA, who is our representative for the Journal Club. So I just want to introduce Dr. Jeff Baker. He completed the Weil Foot and Ankle Institute Fellowship in 2004, and he's currently the Assistant Program Director for the Advocate Illinois Masonic Medical Center Podiatric Medicine and Surgical Residency Program. It's a mouthful. He is a previous member of the FACFAS board of directors, and we're excited to have him here in support of PICA. And thank you guys for always supporting the journal clubs.
Thank you for having me. Appreciate it. Looking forward to it and the
Awesome.
discussion.
Thank you. And then Dr. Patel and Dr. Parupia, it says Christy King, nice job, Parupia, are authors of one of the papers. So we have them here too to discuss some of the paper contents and ask them questions about that. So on that, I will hand it over to Dr. Guerrero to start the presentation.
Perfect. Thank you so much, Dr. King. All right. Can everyone see my slides?
Yep, you're all good.
Excellent. So again, thank you for that nice introduction, Dr. King. Thank you to the college for having us here, Dr. Wynes and myself. Thank you again to PICA for supporting these monthly journal clubs. So I want to start off by providing a little bit of an outline of what we're going to talk about today. So the topic of focus that we want to discuss today is the correction of progressive collapsing foot deformity. And the question that Dr. Wynes and I both specifically posed is whether or not correction can be achieved by fusing the subtalar joint exclusively and maintaining both the talonavicular joint and calcaneocuboid joints. Historically, we know that an advanced Johnson-Strom stage 3 warrants a triple arthrodesis, but can the direction of that deformity be achieved without violating the TN and CC joint, especially when there is no concern for arthritis in those joints? So the overarching question is, how much fusion is enough? This journal appraisal is meant to challenge the teaching that a rigid or stage 3 posterior tibial tendon dysfunction necessitates a triple, as there is sometimes concern for fusing the talonavicular joint, as it can limit the motion in the hindfoot and it can stiffen the foot and increase strain on adjacent joints. So again, plan of attack is to discuss the first article, go over a little bit of a summary, and then the critical appraisal using the University of Oxford appraisal sheets, and then the second article summary with a critical appraisal, any questions, and then we have a little bit of a fellowship summary at the end. So let's dive in. The first article is entitled Isolated Subtalar Repositional Arthrodesis compared with triple arthrodesis for the treatment of progressive collapsing foot deformity. This was published in JFAS in 2024 by Dr. Kim et al. It's a level 3 retrospective comparative cohort study, a single center study completed in Korea that evaluated data from January 2010 to December 2018. The primary aim of this journal article was to compare the results of an isolated subtalar repositional arthrodesis with a triple or double arthrodesis. The distinction that I want to make early on here is that the triple arthrodesis and double arthrodesis was clumped, that group was clumped together. So there are only two groups that are being compared in this study. A secondary aim that was also considered was to investigate the various factors that affect postoperative talar tilt in these patients. So in terms of patient selection and methods, the inclusion criteria and exclusion criteria are as follows. The inclusion criteria consists of patients who have deteriorating degrees of hindfoot valgus, forefoot abduction, forefoot or midfoot varus, peritalar subluxation, and ankle instability, who also have persistent pain despite 12 months of conservative care. The exclusion criteria is follow-up less than 4 years, general laxity of the foot or ankle, foot trauma, or congenital abnormality. With this inclusion and exclusion criteria, the study found 22 feet of 21 patients, and 13 of those feet belonged to the people in the subtalar joint group, and 9 of those feet belonged to the people in the triple/double group. So the outcomes that were measured were radiographic parameters. Weight-bearing X-rays were taken of each foot at the preoperative period, the 3-month postoperative period, and the 4-year postoperative period. The angles that were included are divided here by radiographic view. In the AP view, the talonavicular coverage angle, the AP talocalcaneal angle, and the AP talo first metatarsal angle were evaluated. In the lateral view, the calcaneal pitch angle, the lateral talocalcaneal angle, the lateral talo first metatarsal angle, and plantar gapping was evaluated. In the hindfoot Saltzman view, the hindfoot alignment angle and the hindfoot moment arm were evaluated. And something, again, that was the secondary aim, they did really want to see whether or not valgus talar tilt was a potential outcome of either of these groups. So they used an AP ankle view to assess talar tilt, and anything greater than 2 degrees was a positive finding. I did want to include the operative technique because there was an emphasis in the journal about the repositional arthrodesis. So in these patients, the talus is typically internally rotated and plantar flex over the calcaneus for, again, people who are experiencing progressive collapsing foot deformity. So their operative technique, they address the talus by externally rotating the talus and dorsiflexing the talus over the calcaneus. They didn't use any bone graft. Intraoperatively, if for whatever reason there was rigid forefoot supination present, they address that with a plantar closing wedge of the first metatarsal base. For the patients in the triple or double group, for all the patients who were in that group, the TNJ was fused, but they evaluated the CCJ, and if there was no arthritis, they left it alone. An adjunctive procedure that they performed, if the heel cord was tight, they did a percutaneous TAL. So for completeness sake, I did want to include the most recently described classification of progressive collapsing foot deformity. It is referenced in the article itself. The classification system that they do use for the data was published by Meyerson et al. In Foot and Ankle International in 2020. So all the patient's deformities were described using this classification system. As you can see, there's stage 1 and stage 2, flexible or rigid, and then A through E, describing where the deformity is and what type it is. So here is a list of the patient characteristics that were included in the study. It shows all the information for the 22 feet that are included. It splits both groups into the subtalar joint group and then the double or triple group. I do want to make note that numbers 15 and 16, as described in the article, are the same person, just the contralateral side. Again, it lists age, comorbidities, the PCFD classification, the procedure that was performed, complications and additional operations. And then something I do want to highlight is, again, this valgus talar tilt component. And what I like that they included is they included at what month they noticed that change happening from the actual initial arthrodesis. So with this, and I forgot to mention before, the radiographic findings were measured by 2 fellowship-trained foot and ankle surgeons at 2-week intervals. They took the 4 measurements of the radiographic angles and averaged them, and that's how they found the actual numerical value. And a similar thing was performed for the PCFD classification. 2 independent surgeons evaluated the data and kind of decided whether or not, or decided the classification. If for whatever reason there wasn't a consensus, it was brought to 2 more senior orthopedic surgeons. So the results, the findings are as follows, and I also have the table on the next slide. In terms of the radiographic parameters in the AP view, the STJ group, all AP view or AP view angles that were measured were improved significantly. In the triple group, just the AP talonavicular covering angle and then the AP talocalcaneal angle improved significantly. In the lateral view, the lateral talocalcaneal angle and the lateral tarsal angle improved significantly in both of the groups. And then the hindfoot view, the hindfoot alignment angle and the hindfoot moment arm improved significantly in both the groups. One thing that I do want to add is that there was no significant difference in the preoperative and postoperative measurements between the two groups at any point in time. And again, here is that table. As you can see on the right, the p-values, the comparison between the actual groups over time was performed by the Kruskal-Wallis tests. Again, most of them are statistically significant, with exception to the triple group for the AP transmetatarsal first transmetatarsal angle. But everything else was actually found to be statistically significant from the preoperative period to the postoperative 3 months and then postoperative for a year. There was comparison between the two groups using the Mann and Whitney tests. However, none of those findings were statistically significant. So just some more of the results leading into now the valgus-Taylor tilt. There were found to be 9 patients or 9 feet of the 22 feet that were listed in the study that experienced a valgus-Taylor tilt. 3 of the 13 were the STJ group, and 6 of the 9 were from the triple or double group. 3 of those feet became symptomatic. 1 required a TAR, 1 an ankle arthrodesis, 1 a revision, triple with a MDCO. The average time of the valgus-Taylor tilt development from the arthrodesis was 8 months. And again, here's that chart. Another chart that actually compared the patients who had valgus-Taylor tilt and had no tilt at all was also used to compare the radiographic angles at the preoperative level and then the postoperative 3-month level. The only statistical finding that was discovered with this article was that the hindfoot alignment angle between the Taylor tilt and the non-Taylor tilt group was statistically significant at 3 months. There were 2 findings that showed borderline significance, and that is at the bottom of the table where it's showing triple versus subtalar. It shows that the triple shows a little borderline significance between the neutral group and the valgus group. Same with the hindfoot moment angle or moment measurement. So the discussion, the overarching kind of takeaway from this article was that there were improvements to the radiographic parameters postoperatively for both the groups. However, it wasn't statistically different between the two groups. Out of all 22 feet, there was no recurrence. And interestingly enough, for the valgus-Taylor tilt, it does conclude that residual hindfoot valgus may be associated with valgus-Taylor tilt, and that possibly more extensive arthrodesis showed tendency to increase valgus-Taylor tilt as well. Now to just kind of go into the article appraisal. One thing I do want to preface is that because this is a retrospective cohort study, there wasn't a University of Oxford sheet that was perfectly in line with that. So I used the one for the prognostic studies. So this first question was the defined representative sample of patients assembled at a common, usually early point in the course of their disease. I thought yes, more or less. All the patients kind of had at least 12 months of conservative care before being included into the study, and they all shared similar clinical or radiographical findings. So I'd say yes, more or less. But again, to call this a true inception cohort is probably not correct because not all of them were originally founded at the inception of their disease. Second, was patient follow-up sufficiently long and complete? I would say yes, it was a really nice long 4-year follow-up. However, the article does list a limitation as they wish they had followed patients longer, even 5 to 10 years, or even do state explicitly that they wish that studies could repeat this kind of testing with a longer kind of time frame. Were outcome criteria either objective or applied in a blind fashion? So no to blind fashion, but the criteria was objective. They were, again, primarily radiographic at 3 specified times. However, there weren't a lot of patient-centered outcomes. It was all kind of just radiographic angles. So what are the results? Both groups showed improvement in the radiographic parameters after surgery, but it did not statistically identify statistically significant differences in postoperative radiographic measurements between the two groups. So subtalar joint repositional arthrodesis produced comparable radiographic outcomes to a double or triple arthrodesis. That's kind of the takeaway. No one can really say that those procedures are equivalent in any way, at least how I interpreted it. Also to kind of reference the valgus tilt component, postoperative hindfoot alignment was associated with postoperative valgus tilt, and valgus tilt was observed more frequently in the triple double arthrodesis group. And again, which I will kind of discuss here, how precise are these prognostic estimates? It's difficult to say because the sample size is so small. I think that is a huge limit to this paper. A lot of the conclusions or takeaways that we can make by reading this are tough to feel concrete or confident about given the small sample size. There were some questions that were included in the PowerPoint template as well. Overall, I do think that this article does give good information. Do I agree with the results? Yes and no. I think, again, it's tough because the sample size is so small. I did leave this in terms of do the results differ from your experience, kind of open to the attendings who are on, or the panelists who are on. And then can we trust the results? Unsure, again, alluding the sample size, and will it change your practice? I do think that, and I will kind of discuss this at the end of the presentation, but really understanding your patient and understanding what that talonavicular joint or the calcaneocuboid joint looks like is really important in procedure selection. So, Dr. King, I'm not sure if there's anything else in terms of the appraisal you'd wanted to touch on.
No, I think that's great. And I think you kind of hit it in the beginning. We have these nice appraisal sheets from the University of Oxford, and I think they do help us give a deep dive into journal articles and not just take, what the abstracts are saying, but really figuring out, how we can apply them or what they're really saying. And so sometimes in the cases of these articles, we have to choose one that best represents it or kind of at least gives us those questions to evaluate it more clearly. So I think you did a great job with that. And, I think taking this article as a retrospective evaluation of the surgeries that they described is important. One of the questions that I had for Dr. Baker, with the research that's out there, when we're thinking about doing a case, whether it was a subtalar joint fusion only for a flat foot or if we chose a double versus triple, and if there's a complication, are these studies potentially used to support the other argument as to why you should or should not have done something?
Yes, so they can certainly support that. I think the real issue is just a lawsuit occurring in any way, shape, or form. So sometimes once a lawsuit has, can you hear me? Okay.
Yes.
Okay.
Mhm.
When it is, when it's in its process of it, you can use some of these things. The unfortunate thing about medical malpractice is you need one quote unquote expert to say that you didn't do it correctly. So medical malpractice works a lot more on opinions than
Mm.
facts in this research. So
Oh, interesting.
The good thing about it is that I think that this shows that there's multiple different ways that you can treat a flat foot deformity. And I don't think there's any definitive consensus on a medical legal aspect of it.
Mhm.
What I feel that is the more important aspect that doesn't get into what we're talking about here in terms of this nuance of the cases is knowing that these patients can be, you can see the ages that were of these patients were, some of the medical history that goes along with them, is more about seeing in cases that will come across to be an expert witness for the plaintiff or the defendant, is more about flat foot cases that go wrong, not from the technique in these things you do, but
Mm,
somebody that gets a venous thrombotic event,
Mm,
someone that has some postoperative infection that wasn't treated well. Yes, you can get into some of the technique things, but it's not as cut and dry, which these two articles are telling us that there's multiple different ways to treat a flat foot. I think if you had someone on a real general aspect that you were using joint sparing procedures when joint destructive procedures or a fusion are more appropriate and dot the I's and cross the T's on those, different story for it. So
mhm,
you have more progressive deformity and you do a suboptimal, but we're always talking about in the medical legal world about deviating from the standard of care. And I don't think this the discussion we're having in a rightful discussion on the fact of, hey, this joint that you can get a non-union in, the talonavicular joint, do we really have to fuse this? It's harder to fuse the position, the fixation
mhm.
you use, as opposed to a subtalar joint arthrodesis, which is more cut and dry in doing things. Can you get away with it, subtalar joint? I don't see just doing subtalar and not doing talonavicular. While you may get a medical expert that says that it's was improper, I don't necessarily know it goes to the point of deviating for the standard of care, if that makes sense.
Mhm.
But you still should be very cautious with these cases, extended non-weight bearing, all the other things you think about that can go along with these patients. Patients that you're doing surgery on when they don't have good enough blood flow because they're older.
mhm.
Those sort of things are more the medical legal aspect. I hope that answers the question on it.
No, absolutely. I think that makes a lot of sense. One of the questions I think Dr. Wynes was talking about a little bit before he got kicked off via the airplane was um, this idea of flat foot reconstruction, sparing a joint or multiple joints and potentially selecting, one or two to fuse. In this article, I think it really focuses on what it's doing to the ankle joint as it talks to that valgus tilt. And with a double or triple, we're taking away more joints, and therefore more of the stress may be going through the ankle joint. While it still happened in some of the subtalar joint only patients. Um, what are your guys' thoughts on just deltoid evaluation, reconstruction, failure? Should we be doing more with the initial procedure to protect the from that valgus tilt and that medial ankle, or is it something that hopefully doing the procedure, whether it's a double, triple, or a subtalar only, and seeing how the ankle responds is a better option?
It's Sandeep here. I could start on that. So I definitely don't think any kind of supplemental procedures necessarily prevent a valgus tilt. Definitely not a prophylactic deltoid repair. Even things I've gone to the extent of like trying to utilize an FTL transfer more often.
Hmm.
And I don't think any of that stuff helps. I think, actually we touched on it a little bit here in the paper. It has everything to do with the heel alignment. I think there's about two or three components. I think it has where the heel sits. I think it has to do with addressing the forefoot supinatus, right? So in a lot of cases, especially longer standing flat foot deformities, you can get the heel right, you can get the subtalar joint actually perfectly well aligned, but there's a residual supinatus, and sometimes people will cheat, trying to fuse the medial column joint or even the TN joint, but doing it in situ and not making it corrective.
Hmm.
And I think that, once that happens, the foot starts to adapt and the force goes through the ankle. And then I think the other one is equinus, right? And you see that again in patients with significant pes planus feet that, when you repair their flat foot, they still have a a little bit of equinus deformity, and we say, oh, well, we'll just do a gastroc, which is probably not enough. And so that compensatory force has to go through something, and it usually goes through the ankle. Because you never see like on the table, like once you fix the flat foot and you take it through range of motion or you provide a tailor tilt, that it's going into valgus. You
Mm-hmm.
hardly ever see that, right? So
Right.
this is something that happens over time, and that 8 month mark that is mentioned in this, even though there's no real good data to support it, it's purely anecdotal, is probably
Mm-hmm.
about right. That's about right, because that's usually when the patients are starting to ambulate more, right? Like we keep them non-weight bearing for up to 2 to 3 months, in a boot for another month, and then probably don't see them back for that 6 to 8 month visit. We're starting to see that tilt happen.
Yeah, I like that this article kind of talked about that timing of when they started to see the valgus. I thought that was an interesting point. So, um, well, great points. I think it's probably a good time to lean into the next article, and then we can continue some of our flat foot discussion.
Great. So this article, Doctors Patel and Dr. Parupia are on the actual call as panelists to kind of help fill any gaps with this article. So please, Dr. Patel and Dr. Parupia, if you want to chime in at any time, please do so. So the second article is entitled Pre- and Postoperative Analysis of Flat Foot Reconstruction Sparing the Talonavicular Joint. It was published in JFAS in 2020. Um, and it's a level 3 study that retrospectively compares preoperative and postoperative radiographs. It's a multi-center study that collected data from 2 locations, one being Kaiser Permanente, Northern California, and then a private practice in Albuquerque, New Mexico, from January 2007 to December 2017. The primary aim that I gathered from this article was to compare preoperative and postoperative radiographs in flat foot correction while sparing the talonavicular joint. So the inclusion criteria and exclusion criteria are included here. The inclusion criteria was patients with painful flat feet, stage 2 or stage 3, Johnson and Schramm, patients who required surgical correction, and patients who had preoperative and postoperative weight-bearing radiographs at 3-month intervals at 3, 6, 9, and 12 months. The exclusion criteria were patients who were younger than 18 and older than 75, BMI greater than 45, and hemoglobin A1C greater than 9.5%. Patients that were not excluded were patients who were smokers, who had comorbidities or other adjunctive procedures. After all is said and done, 56 patients were included in the study. So the methods in terms of their radiographic parameters are as follows. The AP view, which I have the angles here to the right that was included in the paper, that evaluated the talonavicular coverage angle, talar first metatarsal angle, and the talocalcaneal angle. In the lateral view, it looked at the talonavicular angle, talar first metatarsal angle, the calc inclination angle, talar declination angle, and the navicular height. So here are the results. The mean age for the patients in the study were 53 or 53.6. The mean BMI was 31.8. There were more females than males. The mean follow-up was about 20 months. However, the min and max was pretty wide, 2 to 73. Like I said, there were smokers, 6 included in the study. The comorbidities that were listed were diabetes, peripheral vascular disease, rheumatoid arthritis, and peripheral neuropathy. And then the complications were also included. And Dr. Patel and Dr. Parupia, now that I have you, I did want to clarify what additional procedures meant specifically, if you guys recall. And I don't know if you want to chime in now or at the end.
You're talking about for the concomitant procedures?
Yeah, it was that. So you know how it says like additional procedure, 15 patients? Is that
I think
just
you mean
talking
for
about?
complications, where it says
Oh,
additional
okay.
procedure right under there.
I think it would be like the hardware removals, if I remember correctly, or something like that, where they,
Got it.
yeah.
Okay. Thank you. And wounds, minor infection, non-union rate, and delayed union. And then it does include the concomitant procedures, which are the gastroc recession, TAL, NC fusion, and first MET cuneiform fusion. So in terms of, oh, before I go there, I did want to discuss a little bit more about the non-unions. There were found to be 8 non-unions. 4 of those 8 were SUJ non-unions, and the other 4 were additional procedures, including 3 NC fusion and 1 first mat cuneiform fusion. The other 4 that had delayed unions did not need surgery. And of the 6 smokers, 1 developed a non-union and 1 developed a delayed union. So here is kind of the tables that were included in the study. In the first one at the top, it shows all the angles that were measured and the means of those angles at the preoperative period at the 3-month follow-up. And to specify at the 3-month follow-up, they included patients who followed up between 3 to 6 months. In the final group, it's patients who followed up between 6 and 2 years. So the top table is showing the minimums and maximums as well as the averages. Where they're doing the comparison, that's in the second table on this slide. It's comparing the preoperative radiographic findings to the 3-month follow-up and then the pre-op radiographic findings to the final follow-up. And so the comparison of those angles from the first group, the pre-op to the 3-month, and even the second group, the pre-op to the final, were all found to be statistically significant. But I do also want to mention that in between the data collection, 10 patients were actually lost between the 3-month follow-up and the final follow-up, which is accounted for in the table above. So kind of my main takeaway from this paper was that there is a statistically significant change in measured angles over time, even without having to address the TN joint directly. It does again mention that there was a non-union rate of 14% in the 4 in the SUJ, 3 in the NC, and 1 in the TMT. In the article, it does discuss that maybe a cotton could have been used for medial column kind of as a medial column procedure, but the means of which they address the medial column were by way of arthrodesis. So, kind of the main conclusion that I gathered was that sparing the talonavicular joint can provide significant and sustained radiographic correction in a flat foot correction that just isolates the STJ plus or minus a medial column fusion. So, in terms of the actual critical appraisal, I kind of went through the same thing with a prognostic worksheet. Was there a defined representative sample of patients assembled at a common and early point in their course of disease? Yes and no. I would say yes, they were all generally had painful flat foots that required surgery, but it wasn't really a clear specification of where they were intercepted as patients. It doesn't really specify if they were early in their kind of disease progression or not. But again, this actual worksheet is difficult to, or it's not exactly meant for a retrospective study. Was patient follow-up sufficiently long and complete? I'd say no. The mean follow-up was about 23 months. The radiographs were followed for a year on average. And then 10 patients didn't complete their final radiographs. And then was the outcome criteria objective? I would say yes. They evaluated objective radiographic parameters. And then what are the results? There is statistically significant improvement to the radiographic parameters when compared to preoperative measurements in flat foot correction while preserving the TN joint, which is what I gathered from the paper itself. And how precise, again, difficult. It's a smaller sample size as well. I do think the article gives good information. I do agree with the results that were presented. Can we trust the results again? Yes or no? It's both of these papers had really small sample sizes. And again, I'd like to kind of pass the baton to Dr. Patel or Dr. Parupia in terms of anything that you felt that I missed or that you wanted to kind of cover with regards to this article.
I think you did a great job of covering the article and kind of hitting the home points. Obviously, retrospective study looking at radiographs, and we're doing kind of radiographic analysis, is going to have a lot of holes or things that we could improve on as far as like making this a stronger study. And losing those patients, makes the follow up not as long. And obviously, we didn't look at any Taylor tilt component to be able to compare that, especially as we kind of go through the progression of the correction over time. But yeah, I think you did a good job covering kind of the basis of what we were trying to hit is essentially the fact that you can get good corrective change without having to fuse the talonavicular joint in these non-arthritic TNs, and be able to have some of that motion as the adapter of the foot to be able to continue to be there and be present.
I think you brought it up a little bit.
Yeah.
Go ahead, Patel.
Oh, go ahead. No, go
No,
ahead.
I was just going to
Go
say, I
ahead.
think you brought it up when you even said it a second ago. And one of the questions I had for you and Perpia would be, the first study kind of presented more of a rear foot addressing, or I mean, I guess in a double or triple, you're going off the TN joint. But when you're comparing a subtalar only to addressing the medial column, I think that may be a more complete way to address the flat foot. And just wanted to get your thoughts. You talked a little bit about the supinatus and stuff, but I was wondering more about the medial column addition that you guys talk a little bit more about.
Oh, yeah. You mean in this paper?
Yeah, like your paper
Yeah.
compared to the previous paper.
Yeah. So I think it's just, again, we obviously didn't have a cohort of TN fusion, which I think, historically, the medial column and some of the transverse plane deformities trying to be addressed with the TN fusion, right? Because again, when you look at preoperative x-rays, weight-bearing x-rays, you see a lot of deformity at the TN joint. Now, I would argue that the majority of these patients that you see don't actually have pain in the TN joint itself, right? It's just a radiographic parameter. And so the idea is to understand that, a lot of the deformity is actually occurring at the subtalar joint, where that's where there's certain level of instability that allows the talus to sublux, right? So you got this peritalar subluxation.
Mm-hmm.
And so the idea is that once you get the calcaneus back underneath the talus, you're essentially elevating the talus. And again, that was alluded to in the previous article by correcting the rotational deformity of the talus. And in doing so, you're restoring the talar pitch, right? But at some point, you're going to have some residual supinatus, and that I don't think often occurs at the talonavicular joint. So,
Mm-hmm.
and you'll see that in the study that once you restore the subtalar joint, that the TN joint actually is articulating like it's supposed to be. It's
Mm-hmm.
well aligned. And a lot of the residual supinatus is either at the level of the TMTJ or the NCJ. And, I think one thing that this paper was published like, 6 years ago. Data gathering was probably more like 7, 8 years ago. So it's quite a while
Mm-hmm.
ago. And I would probably tell you, over the course of that 7 to 8 years, I would probably start leaning more towards a cotton. I think that is a procedure that I employ a little more for the reasons of trying to avoid a non-union, but I think it's also a little more powerful. And it's a lot easier to get your supinatus corrected and get the first rate down through a cotton, as long as the NC joint and the TMTJ are stable, right? If you get a significant fault in one of those joints, that's a relative contraindication. But and again, I think that point is also needs to be stressed because of the concern of developing a hind foot valgus and kind of a undercorrected forefoot supinatus. Because I think the ankle joint's the one that compensates when that
Mm-hmm.
happens.
And you guys documented the additional procedures of the gastroc and more of a distal TAL, I think I assumed from the second procedure. The previous study kind of talked about percutaneous TAL. Do you lean towards either one of those now, or are you looking for, if you want more correction, are you doing more of a TAL and then a little bit of correction of the equinus, more of a gastroc, or where has your experience led you at this point? Either of you.
Yeah, I mean, I'll go first. I can let Yasser answer too, but I still kind of lean towards the gastroc, just as a creature of habit. And obviously the Achilles is so important, right? So over lengthening the Achilles is kind of a scary thing. And I think with a percutaneous TAL, that's always a risk, especially in an adult. So but I do think there's the risk of uncorrecting or under lengthening with isolated gastroc. So I don't know. I know that's not answering the question. It's kind of pussyfooting around it, but it's kind of one of those things where, yeah, some cases you're probably going to need to do the TAL to get a proper reduction.
Yeah. Dr. Perpia, where do you lean these days?
So when I came out of residency and I was doing flat foot reconstruction, I was doing a lot of gastrocs, and it was pretty much a go-to. I didn't want to lose the power that you can lose from a TAL, even with the gain that you would get from the length. Subsequently, as I've continued to do more of them, the level of deformity I find to be more important. If they got a significant valgus that I'm trying to correct through a subtalar joint fusion, or even if I'm doing a Coots, I've now started leaning more towards a TAL. I found that it was significant in its difference, and I know this is not pertinent to this specific subject topic, but we were having radiology rounds with the residents, and there was a patient that was presented as a flat foot case that, when I was in residency training, it was a slam dunk Evans. That's the one you're going to do. The shift was a lot in the transverse plane. Like, if you're not going to fuse it, you're going to do an Evans procedure to get that correction. And the surgeon that was there did a TAL and a Coots, and he slid the calc over almost all the way over to where it was hugging for about a centimeter. But with that shift, just isolating, he was cool because he took fluoros through this process. Just that shift alone with the TAL and the shift in the calc, the TN was completely reduced. It was in perfect alignment. And so we kind of went through a couple of these case studies. He had been doing them for years. But it changed my level of pull on TALs for sure. I feel like when they got a huge flat foot you're correcting, they've been stuck in their position for quite a long time. Shifting that over really allows you to get the calc in a really good position so you're successful without having to take down the TN joint.
And then maybe a question I have for Dr. Baker. I think flat foot is one of those types of issues that has a lot of different recipes, and maybe it's your residency training or your experience that starts to change that. Are there certain things that we should be documenting more? You mentioned a little bit about like comorbidities and things like that, but is there anything you think we should be documenting better, when we're doing something with a flat foot and using just our recipe that we've developed for that?
So I think the main thing, which is probably to everybody is not surprising, is there's an aspect of conservative care. So you got to document that in terms of a generalized aspect of things. One of the aspects is a lot of people that are on this call may be people that are referred patients to them from surgical management for people that do the conservative management. Make sure you document what somebody else does, that it doesn't look like your first visit is just talking about surgery, which it may be because you're a surgeon and you get referrals for these types of cases, but make sure you put into your documentation that conservative care has been performed ahead of time. In terms of the overall, what was the other portion of your question? I threw myself off by making sure I said conservative management. I'm sorry about that.
No, I think that's a great point. It was more just, I think among a lot of procedures, there's so many different recipes, especially for flat foot. Is there something that you need to document early with that?
I mean, if you go backwards on it, and we get into a lot of different things that you can take care, and the example that was just given now with doing something that addresses the frontal plane most often, but then gives you transverse plane is kind of talking about that planal dominance. If you're going to look at the procedures that you do, there should be some aspect that it is that you don't have to say that this is the procedure that's done for this flat foot, but there's an aspect of saying why you're doing each of these, why you're fusing versus joint sparing, why if you're joint sparing, why are you doing these particular procedures for it, that each of them have their own aspect of it. When you're doing some combination, which we've talked about a lot more today in terms of your, stage 3, if you want to say, rigid or partially rigid, that you're doing some aspect of fusion, but then doing some extra articular osteotomy at the same time. Just the reasoning why you chose that recipe. I think you just have to document the fact of why doing that. And I think we get into a lot of trouble with how busy we are, what the EMR systems do. Some of the EMR systems that we use now that have some pre-baked in information about what you're going to do, that you really have to, on your surgical consultation day with these patients, spend time with them and make sure that you document the reason why you're choosing this particular surgical management for it. I think that there's a lot of different ways to take care of this, but if you were ever questioned later on, it's that you've done due diligence and your note kind of backs up the reason why you've taken these steps to do these particular procedures to address the overall deformity, depending on all three planes or one plane, fusion versus joint sparing.
Awesome. Thank you. And then I want to make sure I address one of the questions that was in the chat. It was about the first article. With just the retrospective design, do we think there was a selection bias for the subtalar only versus the double triple that may have impacted the valgus tilt? I think that was also thinking that there's probably some kind of selection bias as to why someone picked doing a double or triple and only a subtalar joint only. So it would be interesting to show, whether it's arthritis or, we saw some of the preoperative angles were similar and then the Johnson and Strom classifications, but, did they pick a double because the TN was more arthritic? I don't think that was necessarily well addressed with the materials and methods. So I think there could have been a selection bias in that, but any of your guys' thoughts on that?
I certainly think there's potential for selection bias. It was good that they said consecutive patients, so they didn't leave people out in that. So they were, but it wasn't. There was certainly the aspect of the surgeon could have the feeling from that particular patient of why they're going to go one route versus the other for it too, and they didn't explain that all that well in terms of why the change and why some patients with the double or triple and some with just isolated subtalar.
I agree. Any last thoughts or questions on the two articles before we get into the discussion of the fellowship?
Hey, Jeff, I have a quick question for you again from about med-legal stuff. So,
Yes.
When you're talking about joint sparing versus not joint sparing, so in that regard, I mean, obviously, most of the things that we fuse, we do it for the indication of fusion, right?
Yep.
But in this case, if you're doing it for flat foot reconstruction, we'll oftentimes take in non-essential joints or fusing joints primarily for deformity correction.
Yep.
So, in that respect, is that an argument, right? Can you just say, hey, we're fusing this joint, not only because of deformity correction? And we know that from at least an evidence-based perspective, we know that fusing certain joints provides that angular correction that we need that then translates to good patient outcome.
I think the advent of going to progressive collapsing foot deformity really does help that out to give you those choices, because when we're in the sort of adult acquired flat foot and our thought process, which was kind of antiquated and it was kind of like, okay, stage 1, stage 2, you're doing joint sparing, you don't get to fusion until 3 or 4. I think that goes away when you reclassify the way progressive collapsing foot deformity is. I think there's some of that bias still in our head in terms of saying, well, this should get fused for not. But I think that progressive collapsing foot deformity gives to right what you're talking about, that this is deformity correction, and we got to think about that more even with just bunion surgery. It's deformity correction. So no, we're fusing things for when they're not arthritic for bunions now because we're correcting the deformity. I think you're spot on with that too. So that's why I didn't really answer the questions that Christy had given us in the aspect of, if you're like, I didn't really feel like the procedure you choose is really the thing that's going to get you in trouble with flat foot surgery on a medical legal aspect of it, because you could have justification on all of these things. But no, fusion for deformity correction is appropriate And I think that you asked a great question on that. I don't think that's something that should be worrisome from a medical legal standpoint in terms of using fusions for deformity correction. Does that answer the question?
Yeah, no, exactly. I just
Awesome. Well, Dr. Guerrero, do you have a PowerPoint for your fellowship?
I do. And again, Dr. Wynes apologizes. He's up in the air currently, so usually he kind of takes the reign on this PowerPoint, but um, I will go over it quickly because I know we're kind of pressed for time too. Alrighty, so the fellowship that Dr. Wynes is the fellowship director for is the University of Maryland Limb Preservation and Deformity Correction Fellowship. I started just this August, so a lot of my insight is very fresh and new, but I'm having a great time so far. Let me go next. So why fellowship? There are a multitude of reasons, but for me personally, I was highly interested in Charcot reconstruction when I got a taste of it in my residency and knew that's kind of what I wanted to lean into. And Dr. Wynes, I feel like, is one of one in that realm. And honestly, he's proven that every day that I've operated with him. I imagine he'd have another answer, but he is also fellowship trained. Um, oh, and this is a picture. One of his favorite things to reference is this is Dr. Lizarov in the OR while someone is smoking a cigarette. So he included his lineage, who he was trained with. He did his fellowship, did his residency at Penn, and did his fellowship with Dr. Lamb at Sinai. The actual fellowship was developed in 2019, so I believe I'm his eighth fellow. And special thanks to Vicki Norton, who I think spearheaded the fellowship at the University of Maryland. It is a FACFAS recognized fellowship, but also GME sponsored by the University of Maryland as well. So it is a fellowship that is recognized by the GME at the institution. So we are fully recognized by FACFAS. Polly Zimnock, she's our program coordinator. She's excellent. I've worked with her a lot throughout the process. The core faculty includes Dr. Wynes, Dr. Michael Berger, and Dr. Amanda Chow. There's a huge emphasis on multidisciplinary kind of work here at University of Maryland. We work very closely with plastics, orthopedic traumatology, and orthopedic oncology. We also work, I imagine we'll touch on this later, but he listed his past fellows. Again, I'm 8, so Dr. Nicole Cates, who's in San Francisco, Dr. Corey Dubois, Dr. Alexis Shoup, Dr. Dominic Casiato, Dr. Chow, who is now faculty at University of Maryland, Dr. Birkelbach, and Dr. Fazio, who was just here. He graduated this past July. And then here's me. Main goal of the actual fellowship. Let me click through this. And if you'd like to read. And then unique aspects to this fellowship. He adds a slide because I think the patient population in Baltimore is kind of one of a kind. There are a lot of sick patients in Baltimore, and honestly, taking care of these patients and treating these patients gives you a unique perspective on how to treat kind of a high-risk patient population. He did include a slide on wound management. We do, as fellows, run a wound clinic on Tuesdays. It's fellowship run. So we do see a lot of complex wounds, and we get kind of a taste of managing these patients long term and kind of seeing them throughout the year. We do TTTs here at this program. And again, a lot of reconstruction at this program. I know that again, Dr. Wynes is known for a lot of his Charcot, but he does kind of everything under the sun in terms of deformity correction, flat foot, cavus foot, complications, revisions, everything. This is actually a case. It's nice that he included this, but this is kind of what drew me to the program. Actually, when I visited, he threw a retrograde limb lengthening magnetic nail, which I had seen kind of on my orthopedic rotations, like peds orthopedic rotations, but he had had great success with one, and I know that there are a couple that we're looking into down the line as well. Again, lots of different recons. We do a lot of Charcot, cavus, a lot of external fixator. We do see babies. We saw a couple today. We see a lot of youth, clubfoot primarily. And then again, a lot of tendon transfers, a lot of X-fix, talar spatial frames. Even in my short 3 weeks of being here, I've thrown a lot of nails, did a couple of talar spatial or a talar spatial frame, a lot of other deformity correcting frames. Let's see. And again, there's such a variety and array of patients, pathology, cases that we see here at the University of Maryland. And there is an emphasis of progressing towards autonomy. Dr. Wynes does an excellent job of teaching, see one, do one, and then also just kind of letting you kind of fly when he feels that you're ready. So some of the dirty cases or some of the more simple cases, he kind of lets you drive. And again, a collaborative team effort, like I alluded to some of the docs who are in the system. They will come into our cases and assist. We do have a really good relationship. Oh, here, perfect. With the vascular surgery team here at University of Maryland. We work very closely with them and do weekly limb board meetings to discuss patients that we're all managing together. We also just had we do our own like journal club with the vascular surgery team, their fellows as well, quarterly. So the relationship that we have with that team is very strong, and we pride ourselves on that. We also here do an orthopedic fellow disputation at the end of the year. I believe Dr. Birkelbach was the first fellow to do that, and Dr. Fazio did it last year. So we are well integrated in the orthopedic surgery department, and we are expected to present alongside, the hand fellow, spine fellow, all of the orthopedic specialties at University of Maryland. So the typical schedule, I'll kind of run through this. Mondays and Wednesdays, we're in the OR. Tuesdays, again, is that fellow run clinic. Thursdays, we're in an office. We do have the option to scrub with outside docs in the afternoons if they have cases. Fridays, clinic, and usually OR in the afternoons or sometimes protected research time. Again, clinical sites, Midtown, downtown University of Maryland campuses, and then Kernan, which is like a outside like surgery center. And again, Dr. Mark Linzer and Dr. Dan Perez are some of the community providers that we can also scrub with. Lots of didactics here. We do a preoperative conference every Tuesday morning, Zoom journal clubs with Baltimore VA and Sinai residents, case conferences, Wound Wednesdays on the first Wednesday of the month, and lots of local conferences that we go to. And then here are a list of publications, highlighted works, abstracts. So very research forward fellowship program. So it's very well rounded. Again, I can speak to my 3 weeks here. I've learned so much in my time, and I feel like there's just so much more to learn. Dr. Wynes is an incredible mentor, and I imagine I'll still say the same thing in a year from now and 10 years from now. So thank you again for having us. And if you have any questions, please don't hesitate to reach out to Dr. Wynes.
Awesome. Well, thank you guys so much for running the journal club this month, and we look forward to seeing everyone next month. Thank you, Dr. Prupia, Dr. Patel, for discussing your article. And thank you, Dr. Baker, for being here representing PICA. And thank you, PICA, again for your support for the Journal Club. Well, we'll see everybody next month. Thank you so much for joining.
Thank you so much, doctors.
Good,
Thanks,
thank
Mickey.
Thank you.
Thank you.